Welcome to the Dermatology Studio with Dr. Yusra Ayaz.
Welcome to the Explainer. We're talking about psoriasis today, and a lot of people think it's just a skin thing, but it's so much more than that. We're going to dive deep into the clinical side of what is a really complex systemic disease. So let's get right to it. All right, so here's how we're going to tackle this. First up, the big question. Is it really psoriasis? Then we'll get into how doctors actually measure just how bad it is. After that, we'll walk through the whole treatment playbook and wrap up with what the long-term picture looks like. Okay, so first things first, the most critical step is confirming the diagnosis. You'd think it'd be obvious, right? But it's not always so clear-cut. There are a few other skin conditions that can look a lot like psoriasis, and that's where something called a differential diagnosis is absolutely key. And this is a perfect example. Take a look. On the left, you've got your textbook plaque psoriasis. See how it's this salmon pink color, the edges are really sharp, and it's got those classic silvery scales on top. Now compare that to what's on the right. That's lichen planus. Totally different vibe, right? The color is way more purplish, what we'd call violaceous, and it has these super fine white lines on it. Those are called Wickham stria. Little details like these are everything when making a diagnosis. And here's another classic mix-up, psoriasis and eczema. Again, look at the psoriasis on the left. The borders are so sharp, you could almost trace them. But then look at the eczema on the right. See how the edges are way less defined, almost blurry? Plus, eczema is usually crazy itchy and can even have these little blisters, which you just don't typically find with psoriasis. It's not just about what it looks like, but where it is and what the scales feel like. Psoriasis, it tends to pop up on extensor surfaces, the outside of your elbows and knees, and the scales are that classic silvery white. Seborrheic dermatitis, totally different playbook. It likes to hang out around the nose, in the eyebrows, on the chest. And the scales, they're kind of greasy and dull-looking. Big difference. Okay, so once we're sure it's psoriasis, what's next? Well, we need to get a handle on how severe it is. And I'm not talking about just a gut feeling. Doctors have specific, standardized tools to actually put a number on the disease and its impact. And the main tool they use, kind of the gold standard, is called the PASI. That stands for Psoriasis Area and Severity Index. It's basically a really structured way to score how bad the psoriasis is by looking at the plaques themselves and, of course, how much of the body is affected. So how does it work? Well, a big part of the PASI score comes from grading the intensity of the plaques. And for that, clinicians look at three things. How red is it? How thick or raised is it? And how much scaling is there? Each of those gets a score, from 0 for nothing at all the way up to 4 for very severe. And then you put it all together. It's basically a 4-step process. You divide the body into 4 main areas: head, arms, trunk, and legs. You score the intensity and the area covered for each of those spots. And then a special formula crunches all those numbers into one final score that can go from 0 up to 72. And that final number is huge because a score over 12, well, that's what tells a doctor they're dealing with severe disease, and that really dictates the treatment plan. But look, it's not just about the skin, right? The disease's impact on a person's life is just as important. That's where something called the DLQI comes in, the Dermatology Life Quality Index. It's a simple 10-question survey that asks about how psoriasis is affecting everything from daily activities to relationships. If that score creeps above 10, it's a huge sign that the disease is having a major negative impact on their life, and that's a massive factor in deciding how aggressive to be with treatment. And we can't forget the nails. A huge number of patients get nail psoriasis. So there's another tool for that called the NAPSI. For this one, you imagine each nail is split into 4 quadrants, and you score the specific signs of psoriasis in each one. Things like the tiny little dents you see here, that's called pitting. It actually happens because there's inflammation way back in the nail matrix, which is like the nail's factory. All right, so we've got a diagnosis, we've got a severity score. Now what do we do about it? Let's open up the treatment playbook. The best way to think about it is like a ladder. You start on the bottom rung and work your way up. And here's that ladder. You can see for mild disease, you start with topicals, creams and ointments. But if things are more moderate to severe, you start climbing up to the next rungs, phototherapy, then systemic drugs that work on your whole body, and then at the very top, you have the biologics. But here's a key thing you notice. If someone also has psoriatic arthritis, that completely changes the starting point. You're looking at systemic drugs right out of the gate. Let's talk about one of the most common topicals, vitamin D analogs. Think of them as traffic cops for your skin cells. They basically tell those overactive cells, the keratinocytes, to just slow down their crazy fast production. They work really well, but you can't just slather them on. There's a weekly limit because if you use too much, it can actually mess with your body's calcium levels. Moving up the ladder, we get to phototherapy, which is basically using UV light as medicine. The go-to first choice option is narrowband UVB. It's safer, especially for kids or during pregnancy. But then there's the heavy hitter, PUVA. That's a combo of a light-sensitizing drug and UVA light. It's more powerful, penetrates deeper, and can lead to longer remissions, which is great. But, and it's a big but, it also comes with bigger risks, like a higher chance of skin cancer down the line, so it's only used for really tough cases. Okay, next rung up, systemic drugs. And a classic one is methotrexate. So what does it do? In simple terms, it messes with the process cells use to make DNA. By doing that, it slams the brakes on both the skin cells that are dividing way too fast and the immune cells that are causing all the inflammation in the first place. It's a real workhorse, especially if someone has psoriatic arthritis, too. Now, with a powerful drug like this, you have to be super careful. Monitoring isn't just a suggestion, it is absolutely required. Patients on methotrexate need regular blood tests, period. They're checking your blood counts, making sure your liver is happy, that your kidneys are working right. It's all about making sure the treatment is helping, not hurting in the long run. And that brings us to the very top of the ladder, biologics. These are the smart bombs of psoriasis treatment. They're not just carpet bombing the immune system, they're incredibly targeted. These are engineered proteins that go after and shut down the specific molecules, like TNF-alpha or certain interleukins, that are known to be the bad actors driving the disease. They can be life-changing, but because they're so powerful and also very expensive, they're really for severe cases where other treatments just haven't worked. So we've covered diagnosis and treatment, but we have to talk about something crucial. Psoriasis is not just a skin disease. That inflammation you see on the skin, it's happening inside the body too, and that leads to a whole range of complications. Let's dig into that and the long-term outlook. Because that inflammation is body-wide or systemic, psoriasis is tied to a bunch of other serious health issues. We call these comorbidities. We're talking psoriatic arthritis, metabolic syndrome, which is a cluster of things like obesity, high blood pressure, high cholesterol, and really seriously, an increased risk of having a heart attack or a stroke. And the number one comorbidity, the most common one by a long shot, is psoriatic arthritis. Up to 30% of people with psoriasis will get it. And this isn't just a little achiness, it's an inflammatory arthritis that can destroy joints if you don't treat it. That's why if someone with psoriasis mentions any joint pain or stiffness, it's a massive red flag that needs to be investigated right away. This quote really just says it all. The frustrating thing about psoriasis is how unpredictable it is. There's just no way to know how long a flare will last, when the next one will come, or how long a period of remission might be. It's a chronic up and down journey, and it's totally different for every single person. So what's the big takeaway from all of this? Managing psoriasis is so much bigger than just putting cream on a rash. It demands a whole person approach. You have to treat the skin, yes, but you also have to be on the lookout for all those related health conditions, and you always have to think about the impact this is all having on someone's actual life. And that leaves us with one last thing to think about. We're getting these incredibly precise treatments, these biologics that can zero in on the exact inflammatory pathways causing the problem. So the question is, how far off are we from a future where we can look at an individual patient, see their specific type of psoriasis, and prescribe the perfect drug for them, a truly personalized approach? It's a really exciting time to be watching this space.